So here we are with cirrhosis. Now, I had mentioned before that cirrhosis is a little more, by the time we get to end stage, there's definitely more, more physiology we'll look at and more things that go wrong with people. And as it gets complex, I'm going to keep telling you to go back to the original things I talked about, the things the liver does for a living, all the functions of the liver. So now, why are they not working? Because we're in this disease state. And I'll tie everything back to help you close the loops on those concepts. So what is it now? Now we're talking cirrhosis. So this is the chronic progressive disease, right? We've talked about all those indications that can give you liver disease. Now it's progressing even further. And the chronic inflammation has destroyed the liver tissue. That's caused fibrosis. It gets real hard and rigid and bumpy and lumpy, and it gives you this cirrhotic state. Hepatocellular carcinoma is a common cause of death because by the time you have chronic inflammation, if it changes the function of a cell, you have a cancerous situation. That's what happens with cancer. The cell is supposed to do one thing, and it's a variant, and it goes off and does something else. So if we do that through an inflammatory process or through medicine, we can cause the same outcome. So what happens here? Now, this is going back over what we've talked about. And I know usually students text us when we repeat things like this, and they said, you said that twice today. You said that 3 times today. It's constructivism. It's a theory of education, and we do it so that you bring that concept from those diseases and that information forward so that you tie it in. So we have inflamed liver cells. They're trying to regenerate. They're ineffective. They get abnormal. You get distorted vessels, almost like varicose veins, if you've seen them in the back of people's legs. You know, they get twisted and distorted. Blood flow is not moving well through the liver because it's diseased. Its bile is not going through the canaliculi and through the bile ducts because they're diseased. And this parenchyma, this mass of the liver, is all nodular and getting fibrotic and all, and nothing's working well. So what happens? The cellular nutrition is diminished. The body's not getting what it needs cellularly. The body's not getting the detoxification of infection and toxins. It's not getting the ferritin stores that are going to make hemoglobin, so it's not getting iron. It's not getting the clotting factors. It's not getting all of that. So not only is the liver irregularly shaped and not working, but it's impairing all the functions of the liver in the end. All right, so demographics, what do we know about it? Well, Lewis tells us when the book was published, it's the 8th leading cause of death. It's twice as common in men than women, and it's not alcohol related. They think it might be risky behavior related. Who knows? I mean, look at all the multitude of causes from cirrhosis and, you know, everything that can contribute to it. We talked about chronic people. They tend to be HCV. And HBV can also be chronic. And it's the most common cause of chronic is HCV and liver abuse, you know, from alcohol also. All right, so we talked about causes on the other page, the HCV and HBV being the primary ones. Any kind of hepatitis can evolve to end-stage liver failure, depends on your comorbidities. But typically it's going to be HCV and HBV that will be chronic. Alcoholism can do it. The non-alcoholic fatty liver disease, it's usually a benign condition, just some fat deposits, not always fat people. Don't go along with that thinking. The non-alcoholic steatohepatitis, this is more severe. There's inflammation with this, and this can cause people problems for sure. The primary biliary cholangitis, this is the small ducts, right? They get inflamed. It's usually autoimmune diseases. People have autoimmune diseases that have this. And the cholestasis can contribute to them having cirrhosis. The primary sclerosing cholangitis, this is the larger ducts. And they not only inflame, but they sclerose, they harden, so they don't flow well. This we see in people. There's an interesting well, I think everything's interesting, but there's an interesting comorbidity between people with PSC and people with ulcerative colitis, which isn't too unusual. They both have an autoimmune component, but it's interesting that it's usually those two together. They don't know why. All right, so What else? Then there's a cardiac cirrhosis. And what is this? This is an old term. And all cardiac cirrhosis is someone who has had long-term right-sided heart failure. So think of the right side of your heart. When we talk about heart failures, we're usually looking at left side in adults, but this is right-sided heart failure. So as blood is coming from the system, from the liver, from every place else, coming up the superior vena cava, into the atrium, down into the ventricle, and the ventricle's not working, it's not going to progress real well. So it backsloshes. So where's it going to back up to? It's going to back up to the liver. So the pressure you have exerted on the liver from long-standing right-sided heart failure can also cause a cirrhotic condition because it increases the pressure in the liver, and it really, we don't see it as much, but it can be the cause of somebody's cirrhosis if they've not been treated well, not sought out treatment, not complied with treatment. So you can also have what they call a cardiac cirrhosis. Not as common, but it's out there. All right, so protein malnutrition, we talked about this. It's a key problem with alcoholics. Alcoholics in general don't eat, they like to drink, right? When they go on binges, they're not saying, gee, I haven't eaten in 4 hours. It can be days they haven't eaten and they're just drinking. So they have malnutrition. Excuse me. Anybody who continues to drink is going to continue to have liver damage, so that's not good. All right, now, the non-alcoholic related cirrhosis can be from obesity. It can be from malabsorption. Somebody can have a malabsorptive problem. They've had a Roux-en-Y, they've had a Whipple procedure, they've had something where we've resected. They could have a bypass, a gastric bypass, the typical kind, you know, the surgical kind, the Roux-en-Y. And they've bypassed a certain portion of the duodenum that's going to, you know, take in your nutrients. And they're circumventing that so that you don't absorb it, so you lose weight that way. So sometimes people who are malnourished and have malabsorption can also, it's going to contribute to their cirrhosis because the cellular nutrition, the overall nutrition, but the cellular nutrition is a problem. Extreme dieting does the same thing. And there's people that do extreme dieting who aren't real heavy and do it just to maintain the way they look, and they can be doing damage over time. Nothing extreme is good. Moderation is always better. So environmental factors can do it. Maybe something in your work area. Thank God since OSHA, we don't see the dry cleaners anymore, the rug cleaners anymore having these issues, but we did for a long time. Without diet and alcohol issues, you can still have something like that. You could have what's a good example? Alpha-1 antitrypsin level deficiency. There's this disease that you don't, the protective enzymes you need for your liver and your lung and your glomeruli and in your kidney, you don't have, you have a deficiency. So you don't have that protection. It can be some odd genetic thing like that. So things to consider, you know. All right, so what are the diagnoses? Well, we're gonna go to the history and physical. They're gonna look at your LFTs, you know. What is your ALK-Phos doing? What is your aspartate transaminase doing? What is your ALT doing? What is your GGT doing? And let's see if we can figure out why they're elevated, okay? They're gonna look at your protein levels, because if you really have liver disease, like we're talking about these cirrhosis, how do they find out about cirrhosis? You're not gonna have good protein. You're not gonna have good levels of albumin. Your serum bilirubin is gonna be out of whack. Your globulins aren't gonna be good, because that's one of the functions of your liver that is no longer working. We're looking at your cholesterol, because in a diseased liver, you can't break it down. We're looking at your PT, because now you're having clotting issues. All those clotting cascade components you don't have. They can do the FibroScan we talked about. That's your ultrasound that talks about fibrosis and the degree of damage in your liver. We can also do that FibroSure. That's using your LFTs and some calculations to get a score. The biopsy is the gold standard. But as we've said before, can we do a biopsy on everybody? If somebody arrives to the ED and the impression is they are significantly cirrhotic, without having good clotting factors, they're not a candidate to be having a biopsy. They'll bleed to death. So it's not always a possibility to take somebody for a biopsy, even though it would be the gold standard. We'd love to get a piece of that tissue and look at it. All right, what are we seeing in early stage? This is early stages of cirrhosis now. It could be insidious things that you're not picking up on. So fatigue and loss of appetite and weight loss. Well, if this is an older crowd, they don't mind weight loss of a couple of pounds. A couple of pounds of weight loss is not making them say, I better get to the doctor. What's making me lose 5 pounds in the last month? You know, people don't think like that day to day. Abdominal symptoms might bring you. If you have tenderness or abdominal pain or, you know, any issues like that related to your abdomen, that might. And if you have that kind of a thing that, you know, you're at the doctor and you have these vague, yes, is someone asking a question? Hello? Is somebody there asking a question? No? Okay. So if you have these vague abdominal complaints, they might just order your LFTs among all your other blood work and see what's going on, okay? It's often not determined until later, until it's more progressive, because by then you're more symptomatic and that's what's going to bring you in to get checked. All right, so what do we see in later stages? Kind of hard to not notice it. People are jaundiced, and yet you'd be surprised how many people come into the hospital and we say, how long ago did you notice the jaundice? Probably 3 or 4 months now. You know, I would think most people, if they looked in the mirror and saw they were jaundiced, would react. But, you know, denial is a powerful thing. And if you're looking and you're seeing something that frightens you, some people can't cope with that. We'll talk about skin lesions, endocrine issues, peripheral neuropathy, all of these things. We'll take them one at a time. These are all things seen in cirrhosis in the later stages. Okay, so jaundice, let's talk jaundice. So this occurs when the liver is not working. Why? Because your bile ducts get clogged. Remember we said, what's the underlying concept? The tissues are inflamed. They start swelling. Now all the blood that used to flow through nice open channels cannot. Now it's going through this tortuous vessel. All the bile that used to come out of those little pink pillows on the picture, all those hepatocytes, and go right into canaliculi and go into bile ducts and go into a common bile duct, it can't get out of those tiny little canaliculi that are the size of a hair. It can't get through there anymore. So now you have cholestasis, okay? Now, this is all causing duct compression. So that's the big deal. Now, bilirubin is yellow, okay? It's a pigment. And it's from the breakdown of hemoglobin. And it's yellow. So your spleen maybe is breaking some down. And you have this yellow pigment. It's insoluble in water the way it is coming out of your spleen. So it comes to your liver where it binds with, you don't need to know this, it binds with, you probably had it already in anatomy. It binds with this glycouronic acid. That makes it soluble. So it can go out as conjugated bile. And what? It goes out into the body, it goes into your stool with stercobilinogen and gives it some color. It goes into your urine and makes your urine yellow. Okay, none of that is happening. None of it. So now you have all this bilirubin, and where's it going? The body's gonna just try to decide, how am I getting rid of it? And the only way it can do that is through the skin. So now the skin is yellow, the sclera are yellow, people are yellow. And there's varying degrees of dyes people can get to their skin. The yellow people get from renal disease is a different cast altogether. The yellow they get from cirrhotic disease, they can be kind of a yellowish tint at first. If they've had it over a long period of time, it almost gets an orangey brown to the skin with the buildup. So there's varying degrees of what they have. And until you've seen them side by side, you can look and say, that's a kidney, that's a liver. You know, it becomes more discernible, but it's hard to figure that out until you've seen it. So the stool will lighten without the bilirubin components getting out to it, and the urine darkens. So that's why we start seeing these things in people. The degree of jaundice with liver disease depends on its severity in terms of long-term. If somebody gets a bout of jaundice from hepatitis A and it goes away, okay. But if they get jaundice and it's hanging in there and it's getting darker over months and this and that, it's probably the severity of their liver disease. But if it fades at all, it is not indicative of improvement. It is not. We have to go by LFTs. Okay, so skin lesions. What are we looking at here? The one on the left here is telangiectasia, these little skinny vascular things here. You see these little spider nevus kind of things? That's called telangiectasia. And it's characteristic. And you will see this a lot in drinkers and alcoholics. If you see their noses, you see all these fine little lines. And really what it is back to your portal hypertension. If the blood cannot come up from the body, all that blood coming to the liver to have it do its thing, and it's stuck there now. Some gets through, but it's not free flowing like it should be. You have this portal hypertension. All this packed buildup of pressure in your liver is going to reverberate out to other vessels, because where else is it going? So where are vessels vulnerable? Well, in the face, you have these tiny little vessels. So we tend to see this. So that's one of the skin things you see. This is palmar erythema. You should be able to hold your hands up and they don't look that beet red. This, when you see it in real life, looks like someone put their hands on a stovetop that was on. I mean, they're really red, 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 red. And it's thought to be from circulating hormones that can no longer be broken down in the liver. So your estrogen, testosterone, all of that circulating, and it gives this color to the hands, and the liver can't break it down, so this is what they're stuck with. It is a telltale sign of someone with cirrhosis. Now, there must be other things that cause it. I worked with a girl in 152 before Diane came, and the first day she met me, she said, "Oh, I'm so glad to see you," and she put her hands up, and she had beet red hands. And she saw me instantly look at them, and she said, "I swear to God, it's not from cirrhosis. It's not. I have palmar erythema." And I said, "What do they think it's from?" You know, we had a good laugh over it. So what do they think it's from? And she said, "They don't know. They think I have just high estrogen levels in general, and it comes out in her hands." But it is very telltale about cirrhosis. All right, so let's look at some hematological issues. So stay with me. We talked about how the liver doesn't have, when it should be synthesizing clotting factors and all of that, it's not doing that anymore. It's diseased. We're in cirrhosis land now. Okay, so thrombocytopenia and leukopenia. Where is this coming from? When you have a cirrhotic liver and you have all this portal hypertension in your liver, the pressure backs up. Like I said, it's going to push against these little vessels in your face. It pushes against the path of least resistance. Wherever the pressure from all this blood can disperse to is where it's going to push back. One of the places it pushed back is your spleen. And it causes splenomegaly, because that's where some of the blood's coming from that's coming to your liver to get detoxified, right? So it pushes back and says, we can't take this much. We have the blood is hardly getting through. I mean, it's getting through, but it's tortuous, not like it did before. And there's no function of filtering in the liver anymore. So it's pushing back, saying, I can't do it. It pushes against the mesentery. It pushes everywhere. And one of the places it pushes is your spleen. So in doing that, it makes it enlarge. You enlarge a spleen does what it does, breaking down blood cells. You enlarge it, it's going to do more and faster. So it starts breaking down your thrombocytes and removing more cells from circulation. So you have a leukopenia, which low white count is going to put your patient more at risk of infection. They're already at risk for infection because in their sinusoids, where they should have functioning Kupffer cells, which are part of your immune system, and they take out bacteria and viruses and toxins, those aren't working either. So when we talk about people being at risk for gram-negative, gram-positive sepsis, this is another compounding reason why. So we all have to have good technique. And remember, wash your hands for every patient. Don't cross-contaminate. Watch where you're dumping, what you're touching. Because this poor patient, while they don't look, necessarily like I'm really immunocompromised, are to the extent that they don't have white cells and they don't have Kupffer cells working in their liver. So they're at great risk of infection. A poor Foley insertion could kill somebody like this. An IV insertion where you haven't swabbed enough and you're just putting it through the skin. Think of the bugs on your skin you're putting into this person who cannot fend this off. So think about your actions as a nurse. You have to really be diligent. All right, so the other thing is it's filtering thrombocytes. We don't need them to get rid of more thrombocytes. We need those thrombocytes from the spleen because we're losing clotting factors in the liver. So you can imagine how these people bleed. They have diminished number of thrombocytes and they don't have clotting factors that they're synthesizing anymore. So this is a challenging patient. Okay, the anemia we talked about, right? They have decreased red blood cell production because they don't have the B12, they don't have the 9, the folic acid. They have poor diet, so they're not doing anything to fortify that. And on top of it all, where are our ferritin stores? You need ferritin to bind with myoglobin to make hemoglobin. And the ferritin stores, they don't have transferrin. They don't have the globulin, the protein that's going to carry it around and make these things happen in the body. So they're anemic, usually significantly anemic. So coagulation disorders, we're back to our prothrombin that's decreased, vitamin K, all those vitamin K dependent clotting factors, they're not being synthesized. We have a patient who could die of a nosebleed. Their nose starts bleeding and it just pours. And these are not people who are systemically hypertensive. They are not. They have portal hypertension, but systemically their pressure is usually not high at all. So they're bleeding, bleeding, bleeding into a pink wash bucket. And how can we get it to stop? We put pressure? No, they don't have thrombocytes. They don't have clotting factors. They go up, take them down to specials. They go up and put a cautery. Okay, that seals that off. Another piece is weak. It rips open. They're going to bleed again. So it becomes a real bleeding challenge. You'll see it in different ways. You might just see petechiae, you know, those purple little dots that come out. You see them in the bends of your arm usually when people that have it. You see it in leukemic patients. You see little purple dots. It's little hemorrhages. We see it that way. You see they bang their leg against the bed. They'll have a huge bruise all down the calf. You know, if they don't, you don't let them stay dependent, hold their leg up, put some pressure, do something for them, because you have to have the insight to understand they can't clot this on their own. Gingival bleeding, you'll be doing AM care for them because they have no energy reserve. You're brushing their teeth and they spit and it's all bloody. You know, people who still have periods have excessive bleeding. And it's not necessarily a fibroma or something, it's probably their liver condition. So think about ways people can bleed. It could be in the urine. I mean, really, they just don't have enough clotting ability. So endocrine issues.
Dr. Benetti?
Yes.
So would that mean that fluid replacement is really important for these folks to like help keep fluid in their vascular system?
Well, we got to think about it because if we're going to increase circulating volume, what are we adding to the portal hypertension? That's going to increase
additional pressure.
So that's why this patient was so good for students to have. And they used to say, oh, not a liver. She's going to ask me a million questions about liver. But it's you know, it's a patient who has something on everything, single system that's going on. So we have to be very judicious with the fluids. And as we start talking about how they get ascites from this, all this congestion in the liver, and it spills out into the peritoneal space, if we're just adding fluid volume, it's going to add to the ascites as well. So it's very dicey. We'll talk about some things we do to help maintain that pressure in the vascular space, but it's a dicey patient. You got to be careful. That's a good question.
Can they get dehydrated? Sorry.
No, we try not to let them get dehydrated. That's not helping, but we can, you know, if we find we're going to give fluids, we can give albumin first to raise the colloidal oncotic pressure, and then give them fluid and give them diuretics so they don't take too much on board. You know, it's a very fine line we have to dance with this, very fine. Yeah, it's an interesting patient to have, really. Okay, so liver plays a part in your adrenal cortical hormones. Testosterone, estrogen. We saw the person with the palmar erythema, right? You can't break it down and we tend to see the redness in the hands. But men are going to have gynecomastia. So men who are always thin are telling you, I can't believe I have these breasts. What's happening? My body's dwindling away and I have this breast tissue. They have loss of pubic hair. They lose their axillary hair. They have testicular atrophy. They're impotent with cirrhosis. This is very difficult for them to deal with because they're starting to realize they will never be the way they were. It's a very hard diagnosis. Older women who are postmenopausal now have vaginal bleeding. It's because they can't manage the role of the hormones in the liver. They can't break this down. They can't keep this and support that. And once she starts bleeding, there's nothing really you can do. It's not a cyclic thing. She doesn't have hormones that are in control of that. And it's just going to further deplete the red blood cells, make her more anemic. Young women who are just starting and are menstruating or have been menstruating maybe 10, 15 years are suddenly amenorrheic because their shift of hormone levels has altered also to what's normal for them and so different for the postmenopausal woman. So the failure to metabolize the aldosterone, which is also in your endocrine system, sitting in your adrenal glands, what does aldosterone do? It increases sodium and water retention, and it dumps your potassium. That's what aldosterone does for a living. So if you're in a hyperaldosterone state now because your liver can't break aldosterone down, you're having lots of sodium, lots of water retention, and potassium loss. Now, what's the big danger of a low potassium? Somebody?
Don't you have like cardiac issues?
Yes, cardiac issues. Very good. So on top of all this, we have all these systems we're going through. You know, we have these skin problems, we have endocrine problems. Now we're at risk for cardiac issues. Now our aldosterone's out of whack. I mean, this is a patient who's really, really complex, very sick. Okay, so peripheral neuropathy. We talked about the deficiency of vitamins. You know, your B1, your B9, your B12, that's your thiamine, folic acid, cobalamin. So without that, people tend with any disease to get neuropathy. So we see neuropathy in cirrhosis, and the sensory deficits are the most common. It's the distal ones first that are the most common, their hands, their feet. And if they're diabetic or something on top of it, that's compounded. So complications. We will go through and talk about liver disease that is compensated. So you have liver disease, but so far so good. All the things are working to some degree. And then we're going to talk about uncompensated, and that's what comes up next. And uncompensated is when you start getting all the complex problems related to this. You have the portal hypertension, you have esophageal and gastric varices, varicose veins that are in the esophagus and in the gastric fundus. You have peripheral edema, you develop ascites in your peritoneal cavity, you have hepatic encephalopathy, patients confused all the way to comatose from high ammonia levels, and we have hepatorenal syndrome, where you have a normal, otherwise normal kidney that is now not functioning because of your liver disease. So they're sick people, really sick people. All right, so we talked about portal hypertension. We're going to revisit, so everyone's on the same page here. This is your changes in your liver cause obstruction of outflow, right? Of blood outflow, of bile outflow, there's obstruction. Venous pressure in the portal circulation gets so bad, it backflows. It's got to find somewhere to go, and it's going to find a vessel somewhere. A tiny one, a side one, a medium-sized one, wherever it can go, because every time your heart beats, another load of blood is coming through. And what's the liver to do? If it can't go through the liver, it's got to go back or around it or something. So the venous pressure builds up. We already talked about it. Causes your spleen to enlarge. You start losing thrombocytes. You lose your white cells. Okay, your spleen is overproducing, getting rid of all kinds of things. The enlarged veins develop. Collateral circulation develops. When your body's in a pinch, it says to itself, do I need another route to send this blood? What am I doing? And what we know from science, you learned about in anatomy, is there's such a thing called angiogenesis. Your body will say, we need somewhere else for this blood to go. Let me find another route. And it will start to develop an offshoot off a vessel that creates collateral circulation. It's how people with completely blocked arteries in their heart are around. You know, like how you hear some star when in the hospital and they had 4-vessel bypass. You know, they were fine yesterday, but they had 4-vessel. How was this person with 90% occlusion in 4 major vessels in the heart surviving? And it's because of angiogenesis. The body comes up with all these little collaterals. They're not great, they're not big vessels, but they'll do in a pinch. So the body here with all this pressure in the portal system is developing little collateral circulation it can go through. It's not going to save it, but the body's trying. It can only do what it can do. Okay, one of the things it does, the places it pushes against, is your esophagus. In your esophagus, you have all these small vessels, and they supply a lot of blood. You've probably all been to endoscopy and looked down an endoscope, and it's pretty red, you know, pretty pinkish. People have good color down their esophagus. And it's got a lot of vascular supply to that muscle, and it's a nice, smooth, even tube. It should be. Well, now with this portal hypertension over time, you have all these bulging, distended veins that were these little tiny vessels that have under pressure gradually increased in size. Now you take a bite of food, it can be enough to rip it open. You don't have thrombocytes. You don't have clotting factors. And the bolus of food goes down and you rip them open and now you're vomiting blood. So they have esophageal varices. Pardon me. We also get them in the fundus. Your esophagus comes down that big curve on the left of your stomach. That big curve has them. They're delicate little vessels that distend over time. And they too can rupture, and they're in an acidic environment. So sometimes it's just gastric acid that makes them open up. But this is a life-threatening complication for people with cirrhosis. You can bleed completely out from an esophageal and gastric varice. So this is a serious problem. You also get this back push of all this congested blood, and it creates what's called caput medusa. Now, if anybody has studied Greek mythology, you know that Medusa, she was this, supposed to be a girl, couldn't tell by looking at her. She's this winged monster thing, she's ugly. And she's the one that all her hair is venomous snakes. Yeah, and so anyway, that's what somebody labeled this, because when you look at their abdomen, it looks like they have all that, like snakes underneath. It must have looked like to somebody. And so they call it caput medusa around the umbilicus. Those are also vulnerable vessels, and they get so stretched out, they get big and thick and ropey, like varicose veins. Hemorrhoids are very common. The backflow of blood, you know, you can get internal hemorrhoids as well as external hemorrhoids. If it's going to do this and cause varices on the inside of your esophagus, it can do it on the mucosal of your rectum and give you internal hemorrhoids that rip open and you have bleeding. So, and you know, these people are once again at risk. So here's two different pictures of caput medusa. Now this one, tell me, how do they have this guy lying down? This is a good example of ascites. You can't get them to lie down like this because they can't breathe. This is a big, huge belly they're going to tap. But this is considered caput medusa also. Now it looks pretty flat to us looking at it, but I bet if we're there, you can see there's some height to this one. I bet if you're there in person, you can see that it's lumpy on the skin, that it's not as flat as it looks here. But this is quite a bit of ascites. And I'm telling you, you will not have a patient, unless they're trying to put a line or something in his shoulder, you will not have a patient with this much ascites able to lie down like this. It flattens their diaphragm. And, you know, even really heavy people can't lay down. You know how they, in those shows you might see on TV, they sit in recliners and whatnot. You lay a really heavy patient down, it flattens their diaphragm. They can't breathe. It's Pickwickian syndrome. And, you know, if you read Dickens, that's his detective guy. But they're big, rotund bellies. And so this patient lying down likely cannot breathe because the diaphragm is just too compressed. So I can't imagine what they're doing there. Obviously, the drop cloth is not over the belly to do the paracentesis. It's over the shoulder, it appears. It looks like the arm is going this way down, like this is the groin here. So I think they're probably working on a chest line or something. Here's another case you tend to see more. See all the roping here? And that's how Medusa's hair looked like. The snakes were all like that. So that's why they call it caput medusa. Okay, so esophageal varices, we just talked about them, right? So the portal hypertension pushes all the little vessels everywhere, makes them be tortuous. I mean, big, distended. Gastric varices in the fundus, those are going to bleed easily also. 80% of hemorrhages from cirrhosis are from esophageal hemorrhages. And I have seen more than my share of people hemorrhage to death from them. It's just an awful thing. And while it's really fulminating and they're just vomiting, and they're trying to get down with a scope to see if they can sclerose them or band them or do something, it's bubbling up on you. You can't even see down the scope to see where you're going. I mean, it's just, you're worried about them aspirating. It's just, it's really hard to control once they start bleeding. So anyway, that's what's going to kill them quickly if something does with cirrhosis. And it can be slow leaks. Some people have slow leaks through the rectum and you see melanoma stools. Some people have slow bleeds other places, gingival bleeding, you know, but when it's a varice, it's bad, real bad. Okay, so let's look at a picture. So this is a good picture. Look at how pale the skin is. This should not be this pale. This person has no hemoglobin at all. This is very, very pale. But the wall should look like this side here. See how you can see there's little vessels in there, but you can't really see them as ropey. There's some that are starting over here, but you can't really see them as ropey. But look how distended this one has become. It looks like a piece of intestine in there. It's long and ropey and bumpy and all. This used to be a little vessel you couldn't see on the surface of this esophagus. And this is how bad the pressure has gotten. So you can imagine they eat a bolus of food, and as it's coming down, just scraping by any of that can open it right up and they're hemorrhaging because there's so much pressure behind it. Look over here. This one is a little bit better in color, I'll give you that, but this is like starting. This is getting all rumply. It should be very smooth, your esophagus. This is getting all rumpy, so this doesn't look good here at all. But look at how tortuous. See, they're smaller here, but look at them, they suddenly dilate and they're big and tortuous. The pressure has to go somewhere and it can't rush through the liver, and every heartbeat brings more. So it's building up and it's gonna find a way out one way or the other. And this is just one of the ways it goes. All right, let me find my cursor again.
Jane,
Yes.
can these cause airway issues at any point in time?
Oh, sure. Because I've been in rooms where they're scoping them, trying to band them. We'll talk about banding in a minute, trying to band them, trying to do something to stop it. And how do you can't intubate them. You're trying to get down. They're saying, maybe we need to intubate. They're suctioning. And if the person isn't vomiting, they'll quick go down with the scope and they'll try and see. It's bubbling, it's everywhere. You can't see. If you can't find the source of the bleeding, you can't stop it. In the meantime, we're suctioning. And sometimes they'll try and intubate the patient to save the airway and then go down again. But you can also make a narrower way to be working when you're trying to get down the same throat that has an ET tube in it. And it can make it more difficult. You know, they're trying to get down there with instruments and whatnot. And oh, definitely. Yeah, people have aspirated, even just vomiting. I've had a patient sitting up in bed vomiting into a pink basket. And they vomit so much and they can't make it stop that they take a breath and now they're choking because they breathed in everything that's in the upper airway. I mean, oh yeah, it's really problematic. So naturally they try and anticipate this, but there's some things you can't control. It's a progressive disease and it's gonna go its course. It's just gonna do. I mean, you can't stop a train when it's out like that. So, yeah. Okay, so here's some collaborative care. So we're trying to control the bleed, right? So whatever you think about the SPACE program, and I know we're not doing that much with it these days comparatively to what we used to do, but I used to say to people, at least medicine benefits from it. You know, people would say, oh, those millions of dollars go up into space, why do we see it? But medicine benefits. We benefit from the technology every time. So when they had to put a moon suit together to send a man to the moon, the very first time, that was going to go up, they needed a suit that was going to control pressure and temperature and absorb sweat and provide heat if they needed it. And it was such an unknown environment. And so into these big bulky suits, they built lines down the sleeves and lines everywhere to monitor and provide air and give heat and extract moisture and do all these things, monitor their heart rate, monitor blood pressure and all these things. And it was lines within lines to do that. And because of that technology, we have things like this. We have, you know, the technology to put a line within a line, like a Swan-Ganz catheter they use in the ICU. We'll talk about in cardiac, or, you know, PICC lines and invasional lines. We have the knowledge then, and we've seen the application to do something different. So here, this is an endoscope. And the endoscope, you can do a billion things off the end of the endoscope. But inside the endoscope is a light, so we can definitely see where we're going. This one is for banding. So this is EVL, they call it. It's endoscopic variceal ligation. So these are all the bands on here. So in theory, what we're doing is we're going down the esophagus and we see these little bulging things, and we're going to circle it with this and release the band, and it ties it off. So this is not someone who's usually in active bleeding. They'll do it if they can. If they find a node like that, they'll try and band it off. But this is someone that we know has varices and they haven't bled yet, and they're going to go down there and see if they can prevent it. So here it is, a live look down the scope. And all this is refracting here, this shining light, because it's inside, the picture's coming from inside the scope. So they've gone over this vessel that looks like it's going to burst, and they put a band around it. Now, remember your underlying patient. The thought is that band will stricture that, and after a couple of days, it will shrink and shrink and shrink and shrink and heal. What do we need to heal? We need nutrition. How much of an eater is your liver patient? Not so much. What do we need if it finally gets to a point, it'll just fall off when it's deciduous enough and it goes away? If they're not healing well, it leaves an open spot behind and they can start bleeding again. And remember, they don't have thrombocytes and they don't have clotting factors. So it's really, really difficult to manage these. A lot of people do well with it, but it's better to get it ahead of time than to wait till they're actively bleeding and try and do something like this. Not that they won't try, they will. All right, so avoid the stimulus for bleeding. This is a big thing for us. We try and teach people. We don't want you taking aspirin. And I mean, what does aspirin have in it? It's a COX-1, COX-2 inhibitor. That's what causes you to bleed, because that feeds into healthy lining. And if it's an inhibitor and it's inhibiting that, then you're not getting a healthy mucosal lining and you can bleed with aspirin. You know how people get GI bleeds. So we don't want someone like this taking aspirin. NSAIDs, you learned about NSAIDs in what, 101? You had 101, you guys, right? No more they won't have, but this is the last cohort, I think. So in 101, you learned about NSAIDs probably. So what are NSAIDs? Well, they're antiprostaglandins. Prostaglandins in the GI tract are protective. We give you NSAIDs, they're antiprostaglandins. So you can erode and get gut rot from that. People get sick to their stomach if they don't eat, right? Alcohol. And if we're dealing with an alcoholic, they're going to keep drinking. And that hydrogen, you know, ETOH breaks down, but it's the hydrogen ion, it's the acid production. It's the acetaldehyde. These are not good chemicals. So it's going to increase their risk of hemorrhage. So what do we do for this patient? One of the things we do is the beta blocker. Now, I don't think there's anything I teach, I don't bring up a beta blocker. It's crazy. It's got a different usage everywhere. So what does the beta blocker do here? I've told you, this is not a patient with systemic hypertension. They do not have a high BP. They don't. They lack circulating everything. I mean, it's not a high BP at all. Let me let somebody in. So what are we doing here? Where they do have hypertension is in the portal system. So we're going to give a low dose of a beta blocker. It does reduce cardiac output just a little bit, but it's going to reduce the portal hypertension. That's the goal of it. Now, you got to watch, because beta blockers are beta blockers, and they're going to do what they do for a living. So this patient does not have a high BP. I have to watch this patient, give them the dose, and monitor their BP. How much does it drop? How sensitive are they to this beta blocker? We do like the effect that it blocks the beta response, because that allows for less response if the body is already sensing that you need a little epi, a little norepi. It's going to make it chill before it gives you that. So it's not working against us that way, but heart rate and BP wise, you got to watch. So remember, you need at least 80 millimeters systolic to perfuse your kidneys. We don't want to give somebody who's got a 90 systolic a little bit of a beta blocker and find that it drops them to 70. Now we're going to have kidney issues, mesentery issues. So, you know, you got to be very careful, and it's used judiciously. And there's usually a parameter. Don't give for systolic under whatever, but you got your job is to watch your patient, understand what we're giving them, and watch it. Okay, what else can we do? We can do octreotide. Now, I used to take anybody who had an octreotide drip on the old transplant floor because it's a great learning experience. You have in your body already a substance called somatostatin that is inhibitory. And we can replicate it outside, and it's called sandostatin, and that's octreotide. It's the same thing. So what does octreotide do? It's an inhibiting hormone. It's going to inhibit, it's going to suppress the body's desire. The body wants to dilate the splenic circulation, all the mesentery circulation. It's trying to dilate it to accommodate it. This is going to inhibit that a little bit. This is going to decrease that added pressure that's coming through just the splenic section usually. Now, the goal is to decrease the portal flow. It's not going to do much for that if it's not going to allow for the splenic circulation to go crazy and dilate. But it's one of the therapies they can use depending on where this patient is on the scheme of cirrhosis. So you might see that. Vasopressin. Vasopressin is a vasoconstrictor. Vasopressin, DDAVP, you probably heard it as, diamino, dearginine, vasopressin. It's, what's it doing? I'm trying to think of applications you would have had in other classes that would have helped you. Well, anyway, it's too working on the splenic circulation and decreasing that so it doesn't dilate, which is going to help you with your kidneys eventually. We'll get to that and you'll understand. But we're trying to decrease the portal flow. And in the ICU, because it's a vasoconstrictor, they put these patients on vasopressor in the ICU because if it's constricting splenic circulation, what's it doing to cardiac? And we have a sick cirrhotic patient. Do they also have cardiac involvement? So, you got to be real careful. And not everybody with cirrhosis will be on vasopressin. Not everybody with cirrhosis will be on octreotide. Because if for that patient, constricting that splenic circulation is going to make the portal hypertension worse, and they're not going to do that. So that's up to doctors. They take it case by case and figure out what they need. But these are possibilities. What else? The banding we do. Oh, the Blakemore. Okay, we can do a balloon tamponade. This has saved many a life I've seen. This is, now you make something in medicine and they put your name on it. Sangstaken and Blakemore made this Blakemore tube. And it works. It's a big intervention, but it works. Unfortunately, nobody calls it a Sangstaken. Everyone calls it a Blakemore. So this, I am telling you, is a garden hose. I mean, if you're out watering your lawn and you have a good sized tube, this is probably comparable. This Blakemore is enormous. So what does it do? We put it down the nose. Let me go to my graph so you can see it. We're going to put this big long tube. I mean, it's so much bigger than an NG tube, than a Foley. It's a huge tube. And this is a balloon right here. And this is a balloon down here. So we're going to take this Blakemore, and people do not like this. You can just imagine. So they put this tube all the way down, and they drop it down into the stomach. Now you can see here, see this little depression I'm pointing to between the esophageal balloon and the gastric balloon, right in here. This is meant for your lower esophageal sphincter. So this takes accurate placement by somebody who is skilled. Now, they can do it down in EGD and make sure they do it right. Oftentimes when I've had people, there's no time to get them down to EGD. They need it fast. So it's kind of anatomy by braille kind of thing. They measure and they go by, how difficult it is to inflate the balloon, the whole bit. Because the last thing we want to do is rupture the sphincter. But they put this down. When this gastric balloon gets down here, they fill it with 250 milliliters of air. That's going to anchor my Blakemore tube. So then we come up here. Most of the hemorrhaging from esophageal varices is the lower third of the esophagus. It's where it's most vascular. So they can inflate this balloon to compress, to cause a tamponade and compress against the walls of the esophagus to stop the bleeding, okay? And it works well. But this has to be inflated first in the gastric so it anchors it, so it can't slide up. Then we go up, the esophageal balloon is inflated. Then this tube comes up and out the nose. We put a pillow under the nose there so we don't have erosion because it will take that section of face off with pressure. And it comes out and we have an esophageal balloon inflation, which will inflate this one. We have the gastric balloon inflation duct, which will do that one first. And then we have one that is gastric aspiration. So we can hook it up to an NG tube, get whatever's in the stomach out. Usually it's blood from the bleeding and that's caustic to the stomach. Now the end of this is connected up, usually to a gauze, to an IV pole, and to a sphygmomanometer, and they put it about 20 to 40 millimeters of pressure per doctor's order. And that's our Blakemore tube. Could save somebody's life, but it is uncomfortable. All right, let me give you a break and I'll finish telling you about what you have to watch with it. So take a little break, get a drink, go to the bathroom, whatever you need to do. Cord, okay. So that's our sang stick, and I'm telling you, it's a garden hose. When you see it, when you first see it, it's a big fat tube, and you wonder how it's down there. And this person cannot swallow. We have this balloon inflated. Nothing goes down that esophagus. They feel like they're choking all the time. They're miserable, miserable. So, and don't forget, we're talking about a liver patient. So if we say, well, we'll sedate them with something, can they break down the sedation? They have a liver that doesn't work. So they have to be real careful what they give them. Whatever you give them circulates days and days and days. If it pulls your pressure down, we're in trouble. Can we just open the IV? Probably not. What are you going to do with all that extra fluid? You know, so you got to be real, real careful. All right. So the patient, we need a patent tube if they have this Blakemore. You got to make sure it's anchored, it's protecting their nose. The columna, this little space here under your nose, just erodes away if you don't have something. You have to have, because it's under pressure besides. You have to have a pillow that comes with it that's underneath. They need frequent oral care so they don't get bugs in the mouth. You know how we know about bugs in the mouth, who's going to give you pneumonias and other systemic infections and all of that. They don't need that, and they don't have a way to fight anything. So we do frequent oral care. They have to be suctioned constantly. They cannot swallow. So that's a problem. Pressure is by an MD order, 20 to 40 on the little monitor, the little sphygmomanometer that hangs up there. And we got to watch for erosion, watch if they're regurgitating. They should not be. Now, putting a tube like that down makes people want to vomit. But we're going to, if we think they're nauseous because they've had so much blood in the stomach and all that, number one, connect that gastric aspirate port out and get that blood out of the stomach. Blood in the stomach makes you want to vomit. So you have to get rid of that. But we're going to give them something for that. Again, we've got to be careful. You give them Zofran, Phenergan. If it knocks them out, they're going to be out for a while because they cannot break it down. But we don't want them attempting to vomit up around the tube, because if they have that inclination, they could rupture their lower esophageal sphincter. You know, we don't want that. So, all right, we've got to be careful. Aspiration is big. An obstructed airway is possible. They cannot swallow. You don't want, they're laying on their back. You don't want secretions to pool and they're aspirating. So you have to be very careful. If, let me go back a picture so you can see what I'm talking about. If this balloon were to rupture or deflate or has some type of deformity, and this air is gone, this tube will migrate up, and this balloon, this esophageal balloon, will cut off the airway, and your patient will die. So we have to keep a pair of scissors by the bedside. And if we see, if you go in and this patient is really struggling and the tube is advanced, and sometimes they've pulled it, you know, that happens too. But if the tube has advanced and the esophageal balloon moves up, it's going to occlude their airway completely. So there's always a scissor hanging next to the gauze that's holding the sphygmomanometer and the tube up to pressure. And it's not a sphygmomanometer, it's a manometer. But there's always a scissor hanging there. And it's so you can cut that balloon port and let the air go so that they can breathe. So, all right, so what's next? Another collaborative care they can do is shunting. You don't see this done a lot with good reason. We'll talk about it and you'll realize what I'm saying. So this is trying to shunt the blood. Let's redirect it mechanically. What can we do if we know all this blood's coming to the liver and it's having a tough time getting through and going anywhere? What can we do to speed that up? Usually after the second episode of bleeding, like gross bleeding, and they know it's that bad and their life's in danger if they keep bleeding esophageally, they'll see if they're a candidate for this. Now, this is what they do. They try and go into the circulation in the liver and cut off branches and redirect the blood, or put a stent in and try and redirect the blood. This is a dicey move for these people. Not only are they already cirrhotic, they don't have clotting factors, they don't have thrombocytes, They don't have the wherewithal for us to go in and go cutting around the liver. So it's not done a lot. Now, since we have the ability now to do more or less invasive things, that we don't have to definitely cut you open and split your liver and do all these things we do, they can do it through a line. It's still going through an IV line, you know, a major vessel. But if they can do it minimally invasive, they may try it. But what it will do is increase hepatic encephalopathy in people. So it's not used if somebody already has severe hepatic encephalopathy. If they're near coma, if they're so confused and just out of it from all the ammonia pickling the brain, they won't do it. The reason it increases the hepatic encephalopathy is if we can redirect blood and suddenly all that pressure has somewhere to go, it's still not detoxified. So all that blood that has all the ammonia that has come from the mesentery, your colon and all, now is going straight shot to wherever it's going. It's found another way to bypass the liver. And all that ammonia gets to the head circulation and the person gets more encephalopathic than they were before. So if someone's really badly encephalopathic, they won't do it. They can do a portacaval, a splenorenal, and then we'll talk about another one they do here. Let's look at the picture. All right, this is a TIPS procedure. This is transjugular intrahepatic portosystemic shunt. That's why we call it a TIPS. So it's going transjugular. It goes in the jugular at the neck. It goes down, it goes transhepatic. And it goes in here, and through this hepatic vein, they're gonna stick it out and take it down all the way down here and connect it to the portal. And what they're doing, now they've stabbed both big vessels. So they have to be thinking it's less invasive than surgery, but they have to be thinking this patient can handle it. So, and maybe they're giving them, you know, fresh plasma, maybe they're giving them some clotting stuff. Who knows what they're doing to mitigate this opportunity. If this is preemptive, they might not be that bad with their thrombocytes yet, and they're doing this while they can. So they've put this bridge between. Now this line they've put in here, the shunt, is not tortuous, it's straight. So the blood coming from down here is gonna go straight line up here, is gonna go straight line up and go right into the hepatic vein and back into circulation. So the thing is, it's not getting detoxified either. So if the blood is high in ammonia and it's letting it free flow through the liver, it's still bringing a lot of ammonia to the brain. So your patient is still gonna have an increased episode of hepatic encephalopathy in the next 24 to 48 hours probably. It does reduce portal hypertension and the portal pressures, and it's better than having to do open surgeries and do shunts that way. So it's something they use more often now than doing the open surgeries, but not everyone's a candidate for TIPS either. So your chance may be gone by the time they even want to offer it to you. You may be past the point. All right, so here are the other shunts they're talking about that are far less common. This is a portacaval. So they're interrupting this site of the portal vein here, tying that off and taking the other end of it and putting it into your inferior vena cava. That's a lot of anastomotic work to do on a vascular space in a patient that has no clotting factors, limited clotting factors. Here, this one is the splenorenal. So here, they're taking the branch where it's coming out and connecting with the spleen and thinking, well, we can at least cut down on the splenomegaly if we can stop dumping all the backflow in there. So they're going to connect that instead to the kidney, which doesn't always bear well for that kidney, but it's another option they can do if they're trying to reduce the splenomegaly. So not great options because it's not a good disease. It's bad. All right, so peripheral edema, this you're gonna see because we talked about impaired synthesis of albumin. Now go back to your anatomy and physiology and remember how you need colloidal oncotic or osmotic pressure to be stable, and albumin does that. And this way it keeps the fluid and blood and everything in the vascular space. When it doesn't happen, the fluid's gonna seep out. So these people don't have enough circulating albumin. So because of that, their colloidal osmotic or oncotic pressure is low. and you get seepage out of the vascular space out into the tissue. So edema can occur before ascites or along with it. We first see it like anybody else peripherally. So you see it ankles and feet, they have pitting edema. And what do we do for people typically with edema in the feet? We go and get them TEDs, right? And what's the premise? What's the concept behind the TEDs? We're putting these tight elastic stockings on you so that we can manually change the oncotic pressure. If we do that, the fluid goes back into the vascular space. You can pump it around and pee it out. That's how that works. So it's a very simple concept. You learn it early on, but we don't have that option here. I mean, we could do it for your feet if you have dependent edema, you know, if we see it in your feet first, but it's not going to change the reason you have edema this time. You know, it's not going to alter that, because what's happening is your albumin is low. So what they'll do is give you an infusion of albumin. And then after that, if they think you have your fluid overloaded, your BP is pretty good, and they don't think you can handle it, and they want you to have a lower BP, they'll give you some diuretics. But to give diuretics without giving albumin is not going to work. You have to raise that oncotic or osmotic pressure in the vascular space first, and then give them the diuretic, and then it will work and you can pee out. As soon as the albumin is used up, you're back to square one. You know, it's a Band-Aid on a hemorrhage. This is not a fix for this at all. We can't give you enough albumin to keep you going if your liver isn't synthesizing it. So we usually see it in the ankles and feet first. Another place you see it in hospitalized liver patients is presacral. Presacral is at the sacral area, but it's in the back before you get down to the sacrum. And students have said to me, well, how would we know that? Well, you assess your patient. I turn everybody over. I have to see everybody's backside. I don't know if they're broken. I don't know how the skin is on their butt. They're sitting in bed all the time. We need to, you know, be proactive and lotion and clean and all of that so they don't get to cube. So you turn your patient over and you look, and you'll see that presacral edema. And why is it pooling there? Because they're laying, even in a Fowler's, they're tipped backwards, and it's going to collect. The fluid is going to collect down there. And it's not as obvious as someone having pitting edema in their feet, but you're going to see it because you're assessing these people. So we see presacral edema, and you have to make note of that. It's something they need to know about. All right, so ascites, we've talked about it here and there and whatever. Let's really get into it. So this portal hypertension, we keep going back to it, right? It's causing all this problem. You have this engorgement of blood that is making its way through, but not at the speed it should be doing, not at the speed it's doing for us now. We don't even know what's happening. So because they don't have enough albumin, their colloidal oncotic osmotic pressure is off, the proteins and fluids shift. They're going to go through that little shrink wrap, go through the glycine capsule, it spills into the peritoneal space. Now, we also talked how they have hyperaldosteronism. So you also have the factor that your sodium absorption, your water retention is all increased, and your potassium's dropping. So all of this together is going to keep this fluid in your belly, in your peritoneal space. And people slosh with it. I mean, it's heavy, it's hard for them to walk with, miserable feeling. A lot of them are nauseous from it, it's miserable. All right, so what are the symptoms? Well, they have abdominal distension and weight gain. This is centripetal in the middle. Their legs are skinny, their arms are skinny. They're not usually fat people, they're malnourished. So their arms are skinny, the legs are skinny, the belly is big and round like the one we saw on that picture. They have striae, the skin is all stretched and they have stretch marks. They have no appetite. If you lay them back at all, they're dyspneic because they're Pickwickian. They straighten out their diaphragm when they lay back and they can't breathe with all this fluid. They look dehydrated. You look at these people, their eyes are sunken, their muscles are weak, their urine output is low. They are not systemically hypertensive. Liver patients are not. So they have hypokalemia, which puts them at bigger risk because they're hyperaldosteronism. They can't break down aldosterone, so they keep dumping K. You know, so what can we do? We can do a tap to the belly and get this fluid out. But again, it's another Band-Aid on a hemorrhage. Once they start tapping, they'll do a paracentesis once a week, then they do it twice a week, and it's 3 times a week, you'll have a patient that when the belly is filling up with ascites, it's leaking out of previous puncture sites, dripping down their legs. I mean, it's bad. It's bad. So they are at risk for spontaneous bacterial peritonitis. Think about this a minute. I've talked to you about altered immunity, right? So their spleen has been overworked, so they have leukopenia. Their liver is diseased, so they don't have Kupffer cells lining their sinusoids that are getting rid of bacteria and all of that. We've talked how they're at risk for sepsis, right? So now you have an acidic state where, because the colloidal oncotic pressure is off, the fluid is seeping out of the vascular space into the tissue. Anything that was in that liver that has yet to be detoxified is now spilling into the peritoneum. You can't have infection in your peritoneum. You know, you die of peritonitis. A lot of people die of peritonitis. It has a high morbidity. So you have this happening. Whatever toxins were in your liver that your liver can't break down, whether it's bacteria, whether it's viral, whether it's just chemical toxin, is spilling into your peritoneal space. So they are at risk for spontaneous bacterial peritonitis. It can happen. So aside from that, when they start doing paracentesis, they take them down, they swab the belly down, they stick a needle in, and they drain this fluid. And they'll have them more and more frequently. So now we have an interruption of the skin, which we know skin bacteria is terrible. I mean, we live with it every day, but it's terrible to someone who's depleted like this. And they're swabbing and cleaning and all of that, but you have a tube going in and out. Now you have a puncture site, you have an interruption in the skin. That's your first layer of defense. Like, they don't have enough problems. So the risk of them having peritonitis is big. It's big. All right, so interprofessional care, what are we doing? Sodium management, don't give them salt. Dear God, they have hyperaldosterone. They're already retaining salt, which brings water with it, right? Fluid removal. If we think they're circulating too much, they'll try and get rid of some of that fluid. Give them albumin, give them a diuretic. You know, that's what's going to help. The only way it's going to get out. Diuretics, they're going to give them K-sparing diuretics. I've seen them resort to Lasix when they think the K-sparing aren't taking enough out, and they have a shot with the window while the window's open with albumin on board. And they say, well, we'll give them 3 runs of K and we'll give them, Lasix because it'll kick in and work better. Now, through all of this, your kidney still has to be working, or all of this is off. And we'll talk in the next couple of slides about a big renal complication we have. So aldactone, amelioride, they're going to give you those first and see. You may see them order something different, but there'll be a plan B. If they order Lasix, they're going to have to supply the potassium, or this patient's in big trouble. Paracentesis is a temporary fix. It's a Band-Aid on a hemorrhage here. The TIPS is always an option, peritovenous shunt, anything they can do to decrease the portal hypertension might decrease the risk of ascites, but it's kind of closing the barn door after the animal's gone. You know, it's not the best plan to do it then. All right, so here's your abdominal paracentesis. And even in this picture, how stupid is this? This guy is lying down. And I know it's a good picture because it shows you, what they're doing. They're putting the tube in and they're going to stick it in the peritoneal space and drain it in a vacutainer. But your patient, number one, with this kind of ascites, they would still be short of breath. You can't lay them down. Number two, it would have to be somebody that's getting paracentesis pretty frequently to have a belly that low. But this guy looks like he's lying down. I don't know how he's staying put. This guy, they're drawing some fluid off first in a syringe, which is most likely because they're going to take a sample and send it to the lab and see if it's got bacteria or something in it. So that's what that is. But otherwise, they hook it up to a vacutainer and they take fluid off. Now, the question becomes, let's see, I thought I had another picture of it. So the question becomes, what do we do here? What kind of effect is this fluid having on the patient? Now, this fluid, when we're taking it off, is not in the vascular space. It's not in the vessels, right? It's in the peritoneal space. But you have to be careful that after they've had a paracentesis, that your patient has good vital signs, that they're good and steady, that they're not showing signs of hypovolemia. Why is this? Because When we take all this fluid out of the belly, and they, they have to be careful how much they take. People in the beginning are real sensitive to it. They'll take a 2-liter, like a Coke bottle. They'll take one of those and they'll see how they do. But somebody who's really progressive, who gets this done all the time, they probably take 5-7 liters at a time. It's a lot of fluid to take out of your belly. Now, we do have to worry about the hemodynamics here, that they're hemodynamically stable, because we're taking all this fluid out and it's not the vascular space. But think of the concept behind it. What's causing all this? Hypertension in your portal circulation. So as soon as we remove all that fluid, there's a release for everything that's bogged up in this portal hypertension. And it's going to find some leeway to say, we still have nowhere else to go, but you know what? The peritoneal space is open now, and it's going to push fluid through the vascular space into the peritoneal space. And in doing that, it can drop your vascular vital signs, even though what we're draining off of them is not in the vascular space. Okay? This is not coming from a blood vessel. This is coming from your peritoneal space. But if we're going to release all of this pressure, all of the residual pressure in that portal hypertension in the liver is still going to find an access way and say, all right, we don't have albumin. We have all this extra fluid. The fluid's just moving. It'll go right through the glycan capsule back into the peritoneum. Doesn't fill up that quick. It won't be like you were tapped today and this afternoon you're all blown up again. In the beginning, it takes a day or two. Sometimes they do it once a week. But the fact is, we've relieved that pressure. The liver's going to respond to that. And the liver's real sick, so the patient's not going to respond well all the time. So we always check the vitals, always. Okay. Now, hepatic encephalopathy. I've touched on this. This is a neuropsychiatric complication of liver disease. That's the big thing. When we start to see this, when you start to see somebody with liver flap, it tells you the nervous system is now involved in this disease. So what do we see? We might see the liver flap first, and we know it's coming then. You know that the nervous system is not reacting well to this level of ammonia. What are they doing to get rid of the ammonia? There might not be anything they could do. Maybe they're treating the patient, it's just not doing enough. So remember, it's the deamination process. Your body's doing a normal thing. Nothing's wrong with their colon at this point, right? So whatever they're eating, the protein, whatever we're giving them, breaking down in the intestine, it converts through deamination to ammonia. The ammonia is going to go back to the liver, where as far as the colon knows, the liver is going to convert it to urea. It gets to the liver, and the liver cannot convert it. The liver is diseased and cannot make urea out of this ammonia. So now there's just straight ammonia in the blood. And now it's going out, it makes its way up to the brain, and the brain cells don't have it. They can't deal with ammonia. It's toxic to brain cells. So you see this patient who is, confused at first, and then they're wandering, they're obtunded, they're sleepy, they're lethargic. You see changes in level of consciousness, which should always make a nurse's antenna stand on end. This is a change in level of consciousness. And if you have a patient that is cirrhotic, that is this sick, you know it's coming. You understand the body process to know. So you're watching for it. So what do we see at first? Well, the asterixis, we'll see that first, the liver flap. Apraxia, doctors will come in and say, here's a deck of cards, put cards out on the table for me. And the patient doesn't have the coordination to do that. Here's a pad and a pencil, draw the figure 8 for me. And they can't assemble things. They can't put things together. That's a cognitive change. Even if the patient's still talking to you, okay, they cannot execute that collaborative task in the brain to put it out on paper, or to stack 3 books in a row, or you give them 3 little Kleenex boxes and tell them to make a triangle or make a stack, and they can't do it. They can't figure it out. The other thing they have at this point that you won't forget when you smell it is fetor hepaticus. This is, you walk in the room and they have this atrocious smell from their mouth. It is not a lack of oral care. It's not a lack of anything. It is really, it's rotting breakdown of everything in the GI tract, and they will exhale, and it's just It's putrid. You'll smell it the first time and you'll be like, that's what Jane meant. This must be fetor hepaticus. It's really very vile. Okay, so collaborative care for encephalopathy, what can we do? Well, the goal is to reduce the ammonia levels. So how do we impact this? We have to go back to how ammonia is created in the colon, right? Lactulose technically is a laxative, and you've probably given it to people. It's kind of thick. It smells like cake batter. It doesn't smell bad, but it's a thick, kind of clear, yellowish liquid, and it traps ammonia in the GI system. So this is a good thing. We want to give them lactulose, but being a laxative, it's going to trap the ammonia and then give them diarrhea and make it get out. So lactulose tends to be the go-to drug. Now, patients are not going to want to have this lactulose, I'm telling you, because they know it's not going to give them cramps necessarily, pardon me, but it's going to make them go, and they don't want diarrhea. They don't want to be discharged from the hospital to home, and even if they're still not able to do a lot around the house, they don't want to be getting up just because they're having diarrhea all the time. They don't like this. Now, we can give it orally. We can give it through an NG tube. If your patient is in the hospital and tubed and unconscious, we can do it that way. We can give it by an enema. But remember, with the enema, that's a lot of vagal stimulation. And your patient is hyperaldosterone. And so what's the big risk there? They have a low K. And now you're going to give vagal stimulation. Some people can't handle this, and they'll have a dysrhythmia and just die. So you have to be very, very careful stimulating the vagus nerve with an enema. Okay, other options. I don't know why they wouldn't take lactulose. It binds and it makes it go, which is good. But if they couldn't for some reason, whatever reason the doctor says, they like rifaximin better, whatever. They can take antibiotic like rifaximin. What do we know about rifaximin? It's not locally absorbed. If you want rifaximin to work for something other than this purpose, we're not giving it PO. So giving it PO, it only has localized effect. It's not systemically absorbed in a PO manner. So what's it going to do? It's going to kill the flora that converts your breakdown, your deamination process. You know, it's going to stop that whole thing. It's going to kill that flora so you can't make ammonia in your bowel. So there's not ammonia going back to the liver. So that's what we're trying to do with that. It's a local, topical absorbed kind of thing. It's not systemic. Now, this is not a laxative. So if we're giving this to your patient, you can't say, oh, they're on rifaximin, that'll take care of it, kill the flora, and then they'll poop it out and they'll be done. What if they're not pooping? You know, we always have to look to people's basic needs. Your patient has got to poo. So make sure we're giving them something to make them go, that we're not just killing bacteria, but we're giving them constipation now, okay? All right, the other thing they can give, you see sometimes, is neomycin. It's the same thing. If you want neomycin to work on something other than this purpose, you're not giving it PO. It's not systemically absorbed PO. You give it and it just does the same thing. It's going to kill the flora in the intestine. So don't let the patient get constipated, right? The other thing we do is if your patient is conscious and they're still functioning some, we're not putting a lot of protein in the diet. Why is that? I check every tray that goes into my patient's rooms ever. Any of my student rooms, the tray's going by, I lift it up and see what's on there. I can't tell you how many end-stage renal disease people I found had 2 bananas going by. You know, what is this? And they tell me, it's the only hospital I've ever seen, that they don't have a dietitian, a nutritionist, check the trays before they go out. So you have picker packers getting this and this and this, and they get what the people want on the diet. But if there's something they substitute, somebody who doesn't know any better is picking it up and substituting it. You've got to look at your people's trays. So let's cut down on the protein if we know protein metabolism is going to fuel the ammonia that we're trying to control. Okay? All right. Now, hepatorenal syndrome. Okay, you got this, okay? By this time, people are like, oh, liver is too much liver. Okay, hang in there. All right, so you have your decompensated cirrhosis, but you have structurally healthy kidneys. Your kidneys are good, good. All of a sudden, we see renal failure. We see azotemia. What's azotemia? You awake out there? Rising BUN and creatinine, right? So we start to see in the daily blood work the BUN and creatinine is rising. What is this? Why is this happening? Well, I have a cirrhotic patient. There's a reason this is happening. All right, they have intractable ascites at this point, right? Portal hypertension and a decompensated liver is causing, it's pushing back on everything. We've talked about that. At some point, it is overwhelming. And the splenic circulation, that's all of your mesentery, celiac artery, everything, all of that coming from the spleen, the pancreas, all your organs, is just vasodilates. It vasodilates because someone has to say uncle and find a place for this blood to go. The pressure is too much. So you already have varices probably, that didn't work. You have all this collateral little circulation, that isn't working. So it causes the splenic and mesentery system to vasodilate. So now I'm going to take you back to anatomy class probably. RAS, renin, angiotensin, aldosterone system. Remember that? By now people are going, oh, don't tell me that. Okay, think about it a minute. I'll remind you. When there's decreased perfusion in the juxtaglomerular apparatus in your kidney, it starts a whole chain of events. Okay, so stay with me now. What we have here is our splenic system has just vasodilated. When a system vasodilates, it decreases arterial pressure, right? So it just gave way, uncle, 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 and all the vessels opened up. So it decreases arterial blood flow. Now, when blood is going into the kidney, if you have a decreased perfusion at your juxtaglomerular apparatus, it releases renin. Your body says, let me release renin. It releases renin, and what's that whole angiotensin aldosterone thing? Renin gets with angiotensin 1 and becomes this material that's now floating along. It comes with ACE converter, your angiotensin converting enzyme. It goes from angiotensin 1 and converts to angiotensin 2, which is a potent vasoconstrictor, right? What's the other thing angiotensin does? It potently vasoconstricts. It retains sodium. It's going to deplete your potassium because it stimulates aldosterone. And this patient is already hyperaldosterone. It releases ADH. So it releases antidiuretic hormone. Your kidney is reacting to the fact that the blood pressure coming into it suddenly dropped. The arterial pressure is down. So your kidney says, I better just stop everything. Because if the body's losing fluid, I don't want urine to go out. I don't want anything to happen. I want to reabsorb fluid and everything back into the peritubular capillaries and add it to the circulation. That's how it's trying to help you because it doesn't understand what's happening in the liver. So, releases ADH and it causes vasoconstriction. So now, all of a sudden you see azotemia. BUN and creatinine are up because you had an otherwise healthy kidney, but because of progressive cirrhosis, and this was the day and time that the splenic circulation just vasodilated, it's now you have hepatorenal syndrome, and now your kidney is not working. So what happens? With cirrhosis, it follows diuretic therapy. Why? Because you've lost a lot of volume of fluid. So you can see hepatorenal syndrome then. You can see that when the body senses that the circulating volume drops significantly, let's close up, okay? It happens after a major GI bleed. So this patient with cirrhosis has been in the hospital and we're keeping all the fingers in the dikes, everything, it's not, opening up and flooding all over the place and we think we have everything covered. And then all of a sudden, this GI bleed comes and the person has lost how many units of blood sitting in a pink wash basin because they've been hemorrhaging, it drops that circulating pressure. And as soon as the kidney senses that drop in arterial pressure at the juxtaglomerular apparatus, all bets are off. Now you're going through the whole RAS syndrome. It happens after paracentesis for a similar reason. You tap all that fluid, that pressure is gone. Whatever's built up in your liver is going to shift, and that pressure can start being tapped, and that fluid start seeping back into your peritoneal space, and your kidney is saying, well, wait a minute, what's happening to all that water that was here before that's now in the peritoneal cavity, and it closes up your kidney. So there's many fronts, and some people have diuretic therapy, are suffering a GI bleed, we're putting a Blakemore down, and have a paracentesis tomorrow. So some people have the triple crown. And so they end up with hepatorenal syndrome. So now you don't have a kidney either. Okay, so drug therapy, what are we doing, right? We do a couple of things. So vasopressin we can do, it's gonna decrease bleeding some because the splenic circulation, the vasoconstriction it causes in the splenic circulation. We talked about that. Octreotide is inhibitory. It inhibits the body from, it fortifies your somatostatin and it inhibits your splenic circulation from vasodilating, so it keeps it constricted. It also affects your glucagon and your other hormones as well, but it's one that they find helps when you have GI problems like this. Propranolol, we're using Inderal. This is propranolol, low dose beta blocker. It is not for systemic hypertension. This patient does not have that. They have portal hypertension. The lactulose, that's your drug that's going to bind your ammonia and give you diarrhea to make you poop it out. Rifaximin, neomycin, locally topical absorption. They don't absorb systemically, not if you take them PO. And it's to kill the flora so you don't create more ammonia, all right? They might need vitamin K. They might need proton pump inhibitors. That's going to stop acid secretion. It doesn't let your chief cells release acid. It interrupts that hydrogen potassium trisephosphatase pump, makes it stop so it does not secrete acid into the stomach. Diuretics, if they're using them, most likely they're case sparing. All right, so collaborative care with nutrition. These people, liver patients, have no energy, none. People with compensated cirrhosis need lots and lots of calories, high in carbohydrate, moderate to low protein when they're compensated. When they're uncompensated, that changes and it goes to low protein, low fat. Protein is restricted in people with encephalopathy because we understand the cause of encephalopathy is circulating ammonia. So we're going to restrict protein so we're not producing more ammonia in the colon because it's going to travel to the liver and we can't convert it. What else? They have protein and calorie malnutrition. If we can, we're giving them parenteral nutrition. If we can't, we're giving them, we're giving them enteral nutrition. If we can't, we're giving them parenteral. So if they're not getting a tube feed, they're getting TPN, getting something. Low sodium diets, they're in a hyperaldosterone state. They are already retaining sodium and water. Low sodium diet. So if this patient is conscious and eating, they hate their food, they hate how they feel, they know this is progressive, it's going to kill them. They're just, these poor people, they have no energy. You can imagine how depressed they get. It's a very difficult disease.
Dr. Benetti? Quick question about the alcoholic cirrhosis patients are protein deficient, but other cirrhosis patients, you want to reduce their protein?
Yeah, because, well, it depends on the state of cirrhosis they're in too, but your alcoholic is protein deficient more so than your starting cirrhotic who is not alcoholic because your alcoholic is drinking its meals. They're not eating food, period, typically. When they go on a binge, they drink. They're not looking to their need for food. They're not cooking. They're not doing anything. So they start off with a protein malnutrition faster than a cirrhotic patient who doesn't have alcoholic disease. Now, a cirrhotic patient who's compensated probably has some protein in their diet, and that's okay. Protein helps us heal and all of that. But when they get uncompensated, And when they start having all these other problems about encephalopathy and all of that, we have to realize the protein is what's driving that. You're breaking down protein in the deamination process is what creates ammonia that when it gets to the liver can't convert to urea, so your body can't get rid of it. So you have circulating ammonia levels, which are going to give them horrible pickling of the brain. And I mean, they start out confused or combative or obtunded or whatever, but they can be in a coma. They can just go straight to a coma and be there till they die. Yeah. So it's
Okay, thank you.
ammonia has a bad effect. So what do? You're the nurse. You're going to assess your patient, check their mentation, check the neurofunctioning. Not just that you have to do neuroscience and you go in and they're done. What did the neuroscience say? What is the change? And then people say to me, well, I didn't have them yesterday. And your point is what? I hate that when nurses say that. If I have new data on somebody, I have to see what it was the shift before. I have to see what it was yesterday. Is this worsening or not? That's why we have records we can all access. So respiratory status. What are their vital signs doing? Remember, they're not going to be systemically hypertensive, but we don't want them so low that they're not even perfusing organs either. So we don't just let people die of horrible things like that. So we're going to be watching to try and avoid other problems. If they're newly decompensated, what can we do to stop the other decompensated issues? Is there something we can do? So close monitoring of these people is important. Oral care. They're frequently nauseous. They can be vomiting, especially if they've had bleeding in the gut. They can have diarrhea, especially if we're giving them lactulose. They need good care, and they're too wiped to do most of it themselves. If you don't do it for them, it's not going to get done. And that's what we do. We meet basic needs all the way up the line. We start with Maslow, right? And we go all the way up the line. So GI symptoms, anorexia, we have to find the way around it. If this person is conscious and aware of food and this and that, what tastes good to you? Let's get a nutrition. I call nutritionists. They work in the hospital. I call them and say, we need you to come in and help this patient figure out what they can have, what they want to have, what would help them best, and let's get some up here and stalk the floor with it. Otherwise, families are going to bring them in whatever they know they like and encourage them to keep eating all the stuff that isn't good for them. So get somebody involved. I use my resources. I call a nutritionist and get them up there. Okay, GI symptoms, watch the hematemesis, watch the stool color, watch the anorexia is an ongoing problem, ongoing. Get them small bites now and then. If they'll take, 5 bites of pudding this hour, we'll try another 5 bites next. I mean, sometimes it's slow steps. I know you don't have an appetite. Take 5 bites from me. And then 20 minutes later, how did that sit? You feel okay? Let's try another 5. You really got to work on this. They're not going to have that effort to want to do it themselves. And you know better. Ascites, edema, you're watching for all of it. And don't think, well, they have some pedal edema, but a lot of people on bed rest with problems have. What does it mean to your patient, to this case? If I see pedal edema for the first time, I turn everybody over anyway, but now I'm watching for sacral, presacral edema. What's happening? Look at the urine color, look at the urine output, electrolytes, coags. I mean, these things are important. I don't want the patient out and walking without shoes, stubbing their feet and whatnot. If they're going to bang a foot and their foot's going to bleed purple because they have no clotting factors, no thrombocytes. We have to, our safety, our extra safety measures will depend on what we know about this patient's condition. Daily weights, not a difficult thing to do. I'm surprised how many times I'm in a room and I'll say, do we have a weight on this person? No, I've been so busy. I've been in here 100 times. I haven't gotten it. It's in the bed. It's in the bed. And monitoring weights is an important thing. So I say to people, take whatever bed clothes you can have on there to do the weight and hit the button, get the number. And then daily weights tell you a lot about somebody, a lot. We'll talk about other disease process that becomes very important. That's pretty, it's not like, how many times did I have to wait for the scale to be available, bring it in, get 4 other people, put them in the scale, hoist them over, put them in and we did it anyway because you had to. We had to know what the weight was. So no laziness, you got to get the weights. Girth measurements are big in someone with ascites. They will have big, long measuring tapes. And you'll see these bellies of 50 something and 60 something. And these people will say, my God, I've never been more than a size 10 or a 36 pant or something. And they don't understand why they suddenly have this huge girth. And that's how we measure it. You mark it off. Peripheral edema, we talked about. Scrotal edema is a big problem for men with cirrhosis, big problem. Their scrotum can swell like cantaloupes, even bigger. I've seen people with end-stage cirrhosis like this, that their scrotum split. They have wound vacs. I mean, and think about it. If someone has swelling in a foot, we said you put a TED. Not much we can do about scrotum. Can't put TEDs on scrotum. So can you bridge a scrotum? Yes. If the patient is lying down flat, you might have a prayer. This is not a patient that lies down flat. They lie down flat, and that acidic fluid presses on the diaphragm. They're dyspneic. They're orthopic. They can't breathe. So you got to sit them up. So bridging of a scrotum is not helping here. And how are we going to change that oncotic pressure to push all that fluid back into that tiny little vasculature and scrotum to get it to go into the circulation and pee it out? Doesn't happen, right? So we got to watch for that. Jaundice, the degree of jaundice, watch how much worse it's getting. Remember, fading does not mean it's improving. Do skin care, put them on air mattresses. If they have pruritus and they're scratching like mad, I've seen them split their skin open, they're scratching so much. So we give them something, give them Atarax, hydroxyzine or Questran is cholecystramine. We give them something for that. Put kerry oil in the water. Use tepid baths rather than real hot or real cold. Little things like that. So for paracentesis prep, sit your patient forward. They cannot breathe laying down. High followers if possible. Sometimes down in specials or wherever they're going to go do it, they'll have them in a, like a medium fowlers. And they'll have them back some so they can access different points to stick. But watch them for electrolyte imbalances, watch for hypovolemia, watch their vital signs. All right, still more to do. Prevent complications, turn, cough, deep breathe, incentive spirometer, range of motion. Don't forget all our basic care needs. Conserve their strength, maintain their tone. Let's do balance, activity, and rest. Whatever they can do for activity, let's have them do it to be able to do something, all right? Patient teaching, this is a chronic condition. If they continue with follow-ups and maintain diet and follow medications and are compliant, we have a hope of thwarting it so they stay compensated, They can't keep going back to hepatotoxic substances. They can't keep drinking. They can't keep having, the NSAIDs, acetaminophen, all of that. We can't keep doing that. So don't assume that all cirrhotics mean alcoholism. That is a common thinking of nurses, and they'll talk trash about people. We don't walk in other people's shoes. Whether it's cirrhotic or not should not matter to you. We're not the ones judging them. We're taking care of them. So we try and help them. It's an addiction. You've had behavioral health. You understand addictions. If it's an addiction, then we need to help them and see what we can do to get them help. Okay, nursing diagnoses. You love these. You love them. Imbalanced nutrition, impaired skin integrity, excess fluid volume, ineffective self-help maintenance. Not anything real unexpected here. Okay, so any questions? That's a lot, cirrhosis, huh? Yeah, it's a lot, I know. But it makes sense, doesn't it? If you take it little bits at a time, it makes sense. Okay, all right, well, anyone who hasn't gotten their pictures taken can go take their pictures. And if you have any questions or concerns, reach out, text me, call me, whatever, and I'll help you. Okay?
Jane, this is Janie.
Hey, darling.
Can you hear me? Is Vincent there?
Vincent, you there?
Yes, ma'am.
Did you get a Zoom from me?
Let me check my email.
Well, if not, send me. Okay, I don't want to hold everybody up, but for some reason people aren't getting my emails, but I